Good morning, everyone. Good morning, respected Director Ma'am, Dean Ma'am, all senior faculties, and my fellow colleagues. Today, I, Dr. Parth Maheshwari, Junior Resident from Department of General Surgery, have got this opportunity to present a very interesting case study in this clinical grand rounds. My moderator is Dr. Naveen Kumar Sir, Additional Professor, Department of General Surgery. So, starting with our case, Mrs. A 52-year-old female, homemaker, a resident of Uddam Singh Nagar, Uttarakhand, presented to us with complaints of pain in the upper abdomen for past 5 years, abdominal fullness for past 4 years, and lump in the upper abdomen for past 1 year. Patient was apparently well 5 years back when she underwent an open cholecystectomy, after 1 week of which she started developing upper abdominal pain. The pain was dull aching, radiating to back, progressive on and off in nature, with no reported aggravating factors, and was relieved after taking the medication. This pain in upper abdomen was also associated with abdominal fullness for past 4 years, and patient also complained of lump in the upper abdomen for past 1 year. The lump felt was insidious in onset. It was non-progressive in size, and was also associated with abdominal discomfort. Patient didn't have any history of vomiting, fever, breathlessness, jaundice, melena, bleeding PR, or loss of weight, loss of appetite. Patient had a past history of hysterectomy, which was done 22 years back in view of fibroids, and open cholecystectomy done 5 years back in view of cholelithiasis. Patient didn't have any significant family history or similar complaints in the family. Patient had a mixed diet, had reported no change in the bowel or bladder habits, was a non-alcoholic and a non-smoker. She attained a surgical menopause 22 years back after hysterectomy. During this course of 5 years, patient had history of multiple hospital visits in the various cities with complaints of abdominal pain. She received medications for the over-the-counter medications for the relief of the pain. She also had history of hospitalization in a local hospital with complaints of abdominal pain 4 years back, where she was managed conservatively and discharged, but no documents were available for it. Summarizing the history, so a 52-year-old female came to us with complaints in the upper abdomen, which started 1 week after her open cholecystectomy done 5 years back. This pain was dull aching, non-radiating, on and off in character, insidious in onset, and which was had no aggravating factors, but was relieved on medication. This pain was associated with abdominal fullness for past 4 years, lump in the upper abdomen for past 1 year, and she had a history of open cholecystectomy, which was done 5 years back. Coming towards the examination, on examining, patient was examined on examination. She was conscious and oriented to time, place, and person. Patient was average build, well nourished, well hydrated. She had no pallor, no icterus, no clubbing, cyanosis, pedal edema, or generalized lymphadenopathy. Patient had a weight of 55 kg, height was 150 cm, and a BMI of 24.4 kg per meter square. She was afebrile to touch. Her pulse rate was 90 beats per minute in the right radial artery with regular rhythm, good volume, with no radioradial or radiofemoral delay. Patient had a BP of 120 by 80 mm of Hg in supine position in the right arm, with a respiratory rate of 20 breaths per minute abdominothoracic type. And saturation was 90. She was maintaining a saturation of 98% on room air. On CNS examination, there was no focal neurological deficits. The reflexes were intact. Power was 5 by 5 for all 4 limbs, and GCS was 15 by 15. On respiratory examination, bilateral air entry was present with normal vesicular breath sounds, and no added sounds were heard. On CVS examination, S1, S2 was heard, and there was no murmurs. On musculoskeletal examination, there was no skeletal deformities or no gait abnormalities. Coming towards on per abdominal examination, on inspection, abdomen was non-distended, umbilicus was in midline and inverted. There was scar mark in the right hypochondrial region, 6 cm in length, which was reaching to the midline. There was also a vertical midline scar in the lower half of the abdomen. All quadrants were moving proportionally with the respiration, and bilateral flanks appears normal. On palpation, on superficial palpation, there was no local rise of temperature or no tenderness was present in the abdomen. On deep palpation, there was a lump of 7 into 5 centimeter palpable in the epigastric region. It was globular in shape, firm, uniform consistency, smooth surface, well-defined margins, freely mobile in vertical as well as horizontal direction, and it was moving with the respiration. On percussion, there was dull note over the lump and the tympanic note on the rest of the abdomen. Bowel sounds were heard on auscultations, and findings of diarrhea were unremarkable. Summarizing the history and examination, so a 52-year-old female presented with complaints of pain in the upper abdomen, which was after 1 week of her open cholecystectomy, which was insidious in onset, dull aching, on and off pain radiating to back, relieved on medications with no aggravating factors. She had a history of open cholecystectomy, which was done 5 years back. There was a scar mark in the right hypochondral region, 6 cm in length, extending to midline, and a lump of 7 into 5 cm was palpable in epigastric region. This lump was globular in shape, firm, uniform consistency, smooth surface, well-defined margins, freely mobile in vertical and horizontal directions, and moving with respiration. On the basis of history and examination, differential diagnosis of omental cyst and or a mesenteric cyst was made.
One question, why was this hysterectomy done 22 years back at such a young age?
Sir, ma'am, according to history, it was done in view of fibroids. Patient had uterine fibroids.
Wandering fibroid views.
Fibroid hysterectomy. And बाकी वो भी remove कर दिया था ovary को. Did she have bilateral cervix?
No, ma'am. Only hysterectomy. The patient had history. Only hysterectomy was done.
Because she has had so many surgeries, not 2 surgeries before, so something related to that can also be thought of.
Right. Why only 2 differential diagnoses?
You can have
more. I think you can. CGM
and was it cystic in nature? Could you feel that this is cystic?
No, ma'am. It was means a firm consistency. It was not a cystic consistency.
Why did you write omental cyst?
Ma'am, because actually the lump which was felt, it was freely mobile in epigastric region. So, means most common means differential for omental cyst.
More differential diagnosis, at least 6, 7.
Just ask the residents if you want it.
Any
give a break, so that you can participate. Otherwise, so.
From the residents, is there any questions regarding the differential diagnosis? Can you make another differential diagnosis?
Anyone? Any surgery residents are there or not?
They know.
No, but they should be.
No, are they there?
Yeah.
They can come and make comments. Even if you know, it's all the more better that you know.
At least
the answer.
From the senior residents?
Practice in speaking out.
अब नाम लेके बुला दो.
हाँ नाम लेके बुला तो नहीं आएगा.
क्या करेगा इसमें differential diagnosis?
Nirmal,
Senior resident.
can you say some differential diagnosis?
Come here.
Please come.
ये भी practice होती है. You should know how to take out the pointer. You should know how to, use the mind. That's also training.
Ma'am, in this actually, the swelling which is mobile in nature, that mobility,
Address the audience.
mobility aspect is there, and mesenteric cyst always need not be a like cystic consistency swelling. It could be firm in nature also. Hence, this differential of mesenteric cyst was placed. But
is it a particular direction?
yes, ma'am. Yes, it along the mesentery, perpendicular to the axis of the mesentery, the movement occurs. Axis is the axis of the mesentery.
What is that?
It is from that ligament of Treats to the right sacroiliac junction joint bone. So, perpendicular to that axis, the movement occurs, but along the axis, the movement will be limited. But the location of the cyst is a little against it is the epigastric region. So it could be the omental cyst, it could be a differential, but according to me, I could think of this only.
You will only think of this one.
Yeah.
So,
The other differential diagnosis.
why don't you think of something else than the cyst?
Other things.
Solid.
Solid.
Yes. It could be foreign body. It could be, no? It could be a foreign body.
No, not foreign body. Pathology. Moving up and down in respiration.
Yes.
Situated in epigastric region, 5 by 7 centimeter. What can you think of?
It could be a gist. It could be
Yes.
arising from the stomach actually.
No, this. You can
Can it be, you said for
From the left lobe of-
trichobezoar or something like that? Not trichobezoar, any bezoar, phytobezoar.
Yes, ma'am. But the mobility per se, trichobezoars. Yeah.
Just as one of them.
In trichobezoar, she could have other complaints as well.
You know, you should know how to explain.
Yes, ma'am.
So rule it out. How?
Points against points in favor of that in favor of a gist would be the location, and the tumor it is mobile and it is the epigastric region location as well. But pointers against would be typically extramucosally. If it has to present, it will present with initially there may be symptoms of GA bleed, upper GA bleed will be there, or vomiting blood, vomiting can be there, melena can be there. So it is not there.
So she's talking about just gastrointestinal stromal tumor.
Why should it bleed?
Since it is
It is not extramucosal, is it?
yes,
Why should it bleed?
if it is large enough, of course, pressure compression.
Only this.
Only this.
Large enough?
Yes, no.
No.
No, I
Most
was
of the
asking
time-
a trichobezoar. Sorry,
Yes, ma'am.
why is it not a trichobezoar?
Psychiatric component of illness in the history, it has to be inquired for that, and as well as vomiting, history of vomiting, and
But will it feel like this?
unlikely. Actually, I have not felt trichobezoar in my clinical practice.
Okay.
Yes,
Trichobezoars are not solid tumors.
yes,
Initially.
initially.
So they are not felt like a discrete mass.
Yes,
When they become very large, they take the shape of the stomach and then they diffuse swelling in the abdomen. And they are very surprisingly, they don't produce any obstruction, but they produce epigastric fullness after meals, which is present in this patient, isn't it?
yes, sir. Could be true.
They also feel hard. They can be hard to work too hard to feel. And when they're large, they'll be palpable only when they're large.
Only when they're large.
It can be large. What to put on?
Or what's it?
Imagine all the anatomical organs over there, which can produce a lump in the epigastric. What else is there?
Left lobe of the liver, but typically if something it could have to be pedangulated
Yes.
to arise from the liver.
Pedunculated, what? Which tumor?
And like pedangulated liver tumors,
Hemangiomas.
hemangiomas could be. Yes.
Or the giant hemangiomas. What else?
Left lobe, epigastric swelling, going up with respiration. What is that very common in India?
Yeah.
Could be cyst hydrated,
They had it.
hydrated cyst, hydrated.
Or behind. And then many more. Then many more. Okay, at least in the right direction.
Yeah.
Epigastric region, liver should be left lobe of
Yes,
liver.
left lobe.
Passage.
So what are the things then? Left lobe, liver, stomach.
Stomach.
What else? Below the stomach.
Can be a stomach pancreatic
Will it
origin.
go with respiration?
It won't move with respiration.
Comply to that. Can it come from transverse colon?
It can come from transverse colon, mesocolon, and transverse colon.
What are pseudocysts?
Pseudocyst.
Pseudocyst.
Lesser action.
Lesser sac from arising from the pancreas, but then mobility will be
If it is
against.
present in transverse mesocolon,
It can move. The mobility will be there. Transverse mesocolon. And
तो जय ने भी कुछ बोला है cervical hurt.
All those people who read case us.
Could be a wandering fibroid. If you see, she had a hysterectomy 22 years back.
yes,
You don't know one subserous fibroid could have been a wandering one. And it's firm. You said firm and consistent.
Yes.
Right?
firm.
And mobile.
Yes,
Maybe in the bedroom.
yes.
Sure. And there are many more.
Yes, ma'am.
Okay.
so momental cyst is very rare. Mesenteric cyst usually don't present in the epigastrium. The common things occurring commonly is the first diagnosis. Okay?
With these differential diagnoses, the following investigations were routine investigations of the patients were sent, and the radiological investigations were done. In the routine investigations, we had hemoglobin was of 10.7, counts were 6,000, platelets was 177, total bilirubin was 0.68 and 0.06, SGOT enzymes were normal, albumin was 4.2, urea creat was 36 and 0.81 respectively, electrolytes were within normal range, PT-INR was 9.8/0.84, viral markers were non-reactive, and amylase and lipase were not significantly raised. Coming towards the radiological investigations, which will be discussed by my fellow colleague from the radiology department of radiology,
What is the name of the fellow colleague?
Dr. Vivek.
Please call them by name.
Good morning, respected faculties, senior residents, and junior residents. I'm here to discuss about the radiology findings in the case. On USG, a well-defined heteroechoic lesion was seen in the epigastrium. There were hyperechoic contents that showed posterior acoustic shadowing, and a differential of dermoid cyst was given on ultrasound. Sequentially, CT of the patient was done. These are the non-contrast CT images of abdomen, axial, coronal, and sagittal images. Here we can see a lesion in the omentum. Talking about the size, the lesion measured around 5.4, is 5, 6, and 7 centimeter in dimensions. Anteriorly, it was reaching up to the anti-abdominal wall. Superiorly was abutting the greater curvature of the stomach, and inferiorly was abutting the transverse colon. However, the fat balance with these structures was maintained. Similarly, the lesion appeared heterodense with areas of hyperdensity within, and a few foci of fat was also seen, the attenuation of which came up to around -70. And on post-contrast images, these are plain and these are post-contrast images. On post-contrast images, we can see the wall showed enhancement.
Is it adherent to the anterior abdominal wall?
No, ma'am.
But it is there quite close.
Yes, ma'am. However, the fat planes can be seen here.
Yeah, in all the steps.
While the internal contents of the mass showed no evidence of any enhancement. Based on these imaging findings of a well-defined mass lesion in the omentum with the heterodense enhancing walls and with a hyperdense enhancing walls and heterodense internal contents with few fat foci, differential diagnosis of omental teratoma and infected omental lymphangioma was given. Omental teratoma, due to the presence of a heterodense mass with few foci of fat content and hyperdense contents, and infected omental lymphangioma, as lymphangioma usually appears cystic. However, in cases when it gets infected or there are presence of hemorrhage or proteinaceous content, it can appear heterodense and the wall can show the enhancement.
Can it be due to some complication of surgery which happened 5 years ago?
Yes, ma'am. It can
Could
be.
it be due to something left there or some mental thing?
Yes, ma'am. It can be. It can be due to some left surgical products. Or insisted granuloma. Gradually, a granuloma is formed, insisting the foreign material. However, most of the time it is distributed by the presence of air foci of foreign material within.
Can it be, then why you are not making that diagnosis? If it can be,
Yes, sir. However, there are no any features that could distinguish it. There should be presence of at least some foreign material to call is something suggestive of a foreign material.
Heterodensity, what is it due to?
It can be anything, ma'am. It can.
You said it is heterodense.
Yes, ma'am.
What is the reason for heterodensity?
Heterodensity, ma'am, is like we said in teratoma, it can comprise of tissues of all the germ layers.
It's more homogeneous, no? This is more.
Usually present much earlier. Okay, alright. What else?
Omental teratoma, infected omental lymphangioma.
So you had the
And-
history, right, when you
We
reported?
had the history.
So based on the history, would you like to add something else?
But on the history, we can add Gossipybioma on the differentials.
So that didn't come in your differential?
Because there was no evidence of any air foci or any foreign material that could be seen within the lesion.
How will foreign material look like?
It's foreign material. It can be hyperdense materials,
No,
suture
it has a
materials.
specific picture. You
Or-
say that thing.
Our sponges can be seen with multiple air foci.
What is that known as?
Gossipyoma.
What is that known as? A picture known as?
Spongiform pattern.
Please wait. You should know.
Spongiform that in Gossipyoma.
Mottled gas appearance.
Air
Mottled
bubbles.
gas appearance. Mottling, gas mottling. Understand?
Yes, sir.
Yeah, gas
Yes.
mottling is a typical feature on CT scan of a foreign body because they enter the. What is the problem here? What can you make the diagnosis of teratoma rather than that?
So there are no gas mottling signs. However, in Gossipyoma, gas mottling can be the gas bubbles can be
What is the Hounsfield unit?
around -1000. Sir.
And what is your finding?
We could see hyperdense foci that was of around fat attenuation, maximum up to -80.
So it was a fat attenuation.
Yes, sir.
Now, if you want to come, please say, you scan.
Yeah.
Diagnosis पता होता है ना exam
That is the main
very difficult to
No, the diagnosis could not be
I
made.
haven't seen the slides, so I really don't know what is it.
Good morning, respected.
Lot of discussion happened preoperatively. All those.
Sir, when we see this lesion, there is enhancing capsule in the periphery, heterodense content seen within the lesion. There is no air foci seen within the lesion. For this lesion has to be said a Gossipybioma, a spongiform appearance or Sir said mottled appearance has to be seen. No air foci seen in this lesion. So first, when we see this lesion, fat component was there. The first differential has to be omental teratoma. Second is infected omental lymphangioma, and ma'am, third component is it is abutting the greater curvature of the stomach. So cystic gist is the third differential. It's the differential diagnosis that has to be said.
Why you are putting a lymphangioma as a better diagnosis than GST?
Sir, because lymphangiomas are more common than cystic gist. Gist normally not cystic in nature.
Can a lymphangioma happen after surgery?
Yes, sir.
Yes, they can. So that's another indication that you prefer a lymphangioma. That a lymph collection, a lymph appearing like a lymphangioma, not congenital but acquired intra-abdominal lymph collections can happen after an abdominal surgery.
Okay, sir.
Could it be hydrated?
So dilated are not that common in this.
What is the Hounsfield unit?
So these are the mean Hounsfield unit.
Yeah, what does it look like? It look like fluid or fat?
So it look like fluid, sir. Some fat components are there.
So you think this looks like fluid? What was the ultrasound diagnosis?
So dermoid.
Can you show us the diagnosis ultrasound? Yeah. Is it cystic or solid?
Sir, heteroequivalent lesion.
Is it cystic or solid?
Sir, some heterodense component are there. No.
Does it contain fluid in ultrasound?
Yes.
Yeah, perfect.
Sir, first, it's a very interesting case. Sir, on ultrasound, it has a it has a echogenic appearance with no evidence such of a cystic component. That's why the diagnosis of teratoma was given. If it had been a cystic component in that, then never a diagnosis of teratoma would have been entertained in this. Second is regarding foreign body and Gossipyoma. Even in retrospect, it's very difficult to say Gossipyoma even on this CT because it's a well-contained structure which has a thick enhancing wall and components which are fat, but there is no calcification. I have not seen the DICOM images whether any
No.
gas foci was there, but whatever image has been shown in that, there is no evidence of any gas. So
Only a little bit of common sense, that there some surgery had taken place.
yes, ma'am.
This structure is looking very close to the anterior abdomen.
And in the abdomen.
So maybe there is something related to that. So you can start thinking about it.
But like a doctor.
Teratomas are mostly congenital.
Ma'am,
सर्जरी पहले हो चुकी है.
yes,
तो देखना
ma'am,
था उसको.
ma'am, but with this appearance of lymphangioma hydrated, these are the diagnoses we will be definitely be considering. As compared to cystic teratoma up the list, it will be the coming, but the low down the list because there is a fat component and no calcification is there. So, but saying it as a Gossipybioma or foreign material is impossible until we see mortal gas appearance and until we see some other hyper dense structure. It's difficult to say.
Can I say something?
Ma'am, please.
So with this kind of history, should have gone to the radiology department saying that it started soon after cholecystectomy, and you all saw this mass and reported it. Would you advise a plain X-ray abdomen? If you advise a plain X-ray abdomen, normally the surgical sponge or whatever has radiopaque fibers in it, so that may have been picked up on plain X-ray abdomen.
The CT itself is sufficient, right?
Pardon?
CT is an X-ray.
CT, yes, but since the history was so strong that it started soon after surgery, why couldn't we do a plain X-ray abdomen?
That's what I'm saying. CT is an X-ray.
Ma'am, CT scanogram is as same as
Achha, I thought a plain X-ray abdomen would have picked it up.
A plain CT says much more than an X-ray because CT itself is an X-ray. It's a tomograph.
He says that it is 1,000 times there.
1,000 times. Yes.
1,000 times
But
more
it's a simple
radiation.
thing to do.
And they were, if you can pick up
On a
something
plain
clinically,
X-ray, yeah.
that's
Or
okay.
clinically and a plain X-ray.
Yeah.
First thing probably is plain
in
X-ray.
past 5 years, nothing was done, no ultrasound, no imaging was done.
Sir, outside ultrasounds were done, but she was she didn't receive any treatment for it. It was done locally.
picked up earlier?
No, sir, no, ma'am. It was not picked up.
Sound which were done previously.
No.
She must have had some investigation.
She had outside.
This is a grand round. So
Just a good, it's a grand round here. The thing is, here there is confusion. There is no problem in diagnosis. It is only confusion. And I mean, whenever there is confusion, there is nothing wrong or right about it. When you have a perfect picture on the CT or for that matter, clinically also, we are motivated to think straight line. When it is not, then probably the AI has come for all these purposes. These are situations. When it is not, that is the time the confusion arises. So, by no means this CT picture, because Gossipybioma, by the way, Gossipybioma is very rare. Nowadays, we don't see them as common like that as used to be previously. And to think of Gossipybioma is a strong sense of imagination. You have to think of that somebody has done something wrong in this patient and left something behind. So that's also a big thought. And something which is arising after the surgery, the first thing which comes in mind is an acquired lymphangioma. This happens very commonly. So post-operatively, abdominal cavity or the peritoneal fluid contains lymph which gets encysted and form a lymphangioma. Probably in gynecological surgeries, you find quite a number of lymphangiomas.
Earlier we saw.
Yeah, I have seen it many times.
Now it's nice.
Open the abdomen, you find a big lymphangioma picked up wrongly in the CT as a tumor or a cystic tumor. The confusion, we sat many times with the radiology people only to understand what is that thing. Now, they were of the opinion that it is a solid tumor with very agitated appearance, mainly because where the confusion arose. The Hounsfield unit was of the fat. It was not anything else. I repeated it. I sat with Dr. Anjum and multiple areas they were picking up, it's fat, it's minus 70, minus 2, minus 130, like that. The whole tumor had a Hounsfield unit of fat, on CT Hounsfields. That then we had to think of what can it be. It's not fitting with anything. This picture, if you go and see in the internet, the mortal gas appearance of a foreign body, cotton-containing foreign body is very typical, and you cannot miss it if you have it. That picture is also similar to a bezoar. So sometimes the bezoar can actually erode out of the viscous and come outside and get encysted by fibrous membranes. So this was the confusion. So before surgery, we still did not have an idea that we are dealing with a foreign body, a retained foreign body, right? We had all possible types of diagnosis which we had before surgery with the radiology, which I have never seen myself also. And they were making these diagnoses were made only from the picture which was there, right? And the thing that which happens after surgery, we kept in mind a lymphangioма. Was it a lymphangioma? Yeah, possibly it can be. But was it cystic? No, it's not cystic. Okay, was it solid? Yes, likely to be solid. How was it solid? It was very rigid solid. Nothing is fitting. And the picture also is not giving any air Hounsfield unit. That goes into minus 200. I said 600. What do you say? How much is the air picture? Hounsfield. 800. It was never there. So this was the beginning of the confusion, which in fact we had nothing else but to operate. Because in surgery it says that if you can't diagnose it or if you wrongly diagnose it, there's another opportunity to open and see it. Of course with an indication. Yes.
Ma'am, what you said about X-ray, ma'am, it is very easy to pick this Gossipyoma if this gauges have radiopaque markers. But but many times these are.
I think last 20-30 years they have radiopaque markers.
That sir can tell whether here also we are using those gauges with marker on, because many times these markers are not seen even in Gossipyoma when we do scan.
This always makes a problem. In private, they are not used.
We are all coming into this fray, not being a surgeon and not ever having done a laparotomy, or people used to say, surgeons especially, when a lot of physicians are discussing about things, they said ki kya, they just keep discussing, they don't see, they have to open and see. So ultimately that is the ultimate test. I was only speaking out of just logical. In fact, I haven't seen. Now I just saw that. But once something has started immediately after surgery, a surgery which has been a laparotomy and for gallbladder. So if there was something already existing, the surgeon would have seen. And the complaint has started after this surgery. So things do come to your mind, not necessarily something like a gauze piece being left behind. There are many other things which can, I think, happen after a surgery. The suturing, the organs which are underlying, if they come into the suture, if the omentum gets into the scar, into the incision, and that gets sutured there. So that can lead to obstructions. Because omentum is a structure in which you can, I think, have obstruction. If it is there, it will lead to cyst formation, or so one can think of a surgical complication in this case. Yeah, so that wasn't there, but these are the things that you have to think of. Once, it's simply common sense actually. And then, of course, whatever it turns out to be, you will open it and see. And you will also post-operatively, I don't know how many investigations you have to do. You don't have to do too many, just to be sure that it is not a tumor which may metastasize during surgery. So you have to plan your surgery that way. Only thing that was bothering me was this hysterectomy which has taken place 22 years ago. At the age of 30, I think she would have been. And whether she had any children, whether you must see the patient as a whole. And you must tell what's happening to her, otherwise, because I think there are some cystic things which can happen after hysterectomy if in the lower abdomen. But that was another thing which was coming to my mind.
The hysterectomy part, what is most of you have seen in UP? No, everybody does. They are given open choice.
There was many years, the hysterectomy was the only treatment for any gynecological complaint.
Not only that, they are given the option that you have a menorrhagia, and they are bothered. These ladies, in UP, the history, Uttarakhand, UP.
Not only UP, whole India.
The thought process is like this, that the surgeon does the hysterectomy, the gynecologist do the labor. So rampantly I used to see surgeons in periphery are operating and doing hysterectomy. What the indication is that you are having menorrhagia.
Well, rapid tha na in Andhra, there was a rapid of this.
So
Entire villages were.
you are having menorrhagia. So permanent solution is hysterectomy, and in the permanent solution, the birth control is also there. So once they gave the option, everybody is eager to take it. They have completed the family, 2-3 children are there, 30 years female hysterectomy, 32 years female hysterectomy. So this was a picture. I still think that is probably there.
I have seen a case, complete third degree prolapse. The patient went to surgeon and surgeon opened the abdomen and was searching for the uterus.
There are horror stories.
Yeah.
There are a lot of horror stories.
Please proceed.
Okay. So after the radiological discussion and
Sir, if it's a frankly solid component, then we definitely go for your biopsy. This is a big mass, so the no role of FNAC as such. We go for biopsy. But if it's a consideration is of ovarian cystic tumor without any ascites, then we don't go for biopsy. We straight away no, because there are chances of spillage and peritoneal spilling. If there is ascites with the cystic component, then and there high index of malignancy, then we take sample. Otherwise, without ascites, consideration being ovarian malignancy, biopsy would be no from our side.
Yeah, can I respond to that?
What's your name, please?
Srija.
Sorry?
Srija.
Srija. Yeah, good question. See, what are you suggesting FNAC for? Diagnosis, right?
Yes.
Yeah. So, was it benign or malignant on the picture? What do you think? Benign. Was surgery indicated or not?
Yes.
Indicated. So, in such a situation, instead of going ahead with another investigation, if it was malignant, that means, planes are altered, or it is infiltrating locally, or it has got some mets in the liver, suspected mets in the liver, that creates the confusion, and that is what people will like to go for a FNAC or true-cut biopsy if it is solid. To know beforehand what are you dealing with, whether this needs a surgery right at this moment, or maybe an anterior adjuvant therapy may be instituted, right? It typically happens for lymphomatous masses, which instead of excision, if you go ahead with the chemotherapy first, they just melts, right? So here the confusion was not about the malignancy or benign. Here the confusion was, nobody could diagnose actually what is this thing. Even I talked to the radiologists, the consultants, they said, yeah, it may be this, it may be that, it may be that. Not that this is this, right? So that was the confusion which the diagnosis could not be made preoperatively. And considering its benign nature, yes, it can be used definitely if it is solid. But the question comes, why should we go ahead instead of going straight ahead to take this out? As all the fat planes and everything is maintained, there is no local infiltration. Make sense?
Any role of PET?
Any role of PET? Yeah, you can go as high as possible.
PET is benign source, right? Why PET?
Yeah.
So after radiological discussion, patient was planned for the surgical exploration of the benign cyst, and patient underwent expiratory laparotomy with the excision of the tumor mass, which was done under general anesthesia and epidural anesthesia. These are the intraoperative images. Intraoperatively, it was found that there was an 8 into 8 centimeter firm mass with well-defined margins and smooth surface seen arising from the greater omentum in between the greater curvature of the stomach and transverse mesocolon. The mass was adhered to the transverse mesocolon, and the specimen extracted was sent for the histopath.
Why did you not pattern C?
So it should be
He wasn't there.
It was a benign.
No, he can answer this question. Even if he's not there, it's a general question.
Should you cut it or not?
You cut and
No,
see.
Cut the cake.
it was not because it was solid, so it was not intraoperative.
Is there any pathology? Is there pathology? Yeah. So should we have cut it or send it as a whole?
You should send it as a whole, sir.
Yeah, that is the problem. They don't want us to
They
cut.
don't want us to
They
cut.
don't want us to cut. And from the beginning, it
Earlier
was-
they used to cut, and now they don't want us to cut the specimen. So we
Because they
send
may
it to
flow
board.
out actually.
So
The
actually,
diagnostic thing may flow out.
the grossing part, during the grossing part,
Sir, it will alter the model.
alter the one. That is the
Many
thing.
of the
Drawing
guys,
Stop cutting now.
they will not give a single cut.
and
They
we
cut
cut
into multiple pieces.
Yeah.
That
And
will alter the mass.
no. They tell that you don't cut, you mutilate the specimen center.
Yes. I have a suggestion since you do frozen cuts and all that, but I think you can even put the pathologist online and show them the mask.
So ideally,
Operatively, and
Actually-
ask them.
actually, this is a good point. Actually, what happens? I've seen what happens in USA. The pathologists are given a call and they come in the OR. They gross the tumor. They cut it according to the various techniques of
So
grossing.
sometimes the surgery may be dependent on that.
Yeah. So they want to know right at that moment if anything more needs to be done. Now, my question was always from the very beginning when I joined here, why can't we do it here?
You will do it very easily. You have the smart operation
You will
theatre,
ask them, why can't we do it
modular
here?
operation theatre. You just transmit your thing to the pathologist. Should always be online. Yes. Sitting when the surgeries are going on. Yes.
So it was not cut.
It was not cut.
Because the feedback is you don't cut the specimen. Send it intact so that they see everything the way it should be grossed. Absolutely right. Because each specimen has a different nature of grossing. Right? So that grossing, if you don't know, you actually tend to mutilate, tend to do a different plane cut you make it, right? So that's the reason why, because it was discussed that it was a solid tumor containing cystic areas, so it was not cut.
Histopathology.
Yes.
Histopathology.
Histopathology will be discussed by my fellow colleague Dr. Akansha from the Department of Pathology.
Good morning, everyone. And we'll be discussing the histopathology part of the case. So we have received a container labeled as mesenteric cyst. We received, yes, sir. The container was labeled as a mesenteric cyst. So we received a single globular fibrofatty tissue piece measuring 6.5 centimeter. Outer surface was smooth and unremarkable. On serial slicing, we have received cyst. We identified lumen with a ball of cotton fiber and gauze piece, which is also attached to the inner cyst wall. Cyst wall measures 0.2 to 0.5 centimeter in thickness. So this was the specimen we filed. So grossly, it was seen that gauze piece is present here. So on microscopy, scanner view, we are seeing dense fibrocollagenous tissue and the fibroadipose tissue, and here we are seeing the suture and gauze piece materials. On higher power field, we are seeing multinucleated giant cells and the granulation tissue. Here we are seeing the gauze piece materials, and on polarizer, we are seeing the bifringes are shown, which is showing that it is a gauze piece. So our final diagnosis was Gossipyoma. Thank you.
Once you see a cut section showing
Yes,
all these fibers, do you need to do all these to
Yeah.
So, but still report has to be given now, so we have to see the microscopy.
And actually, if we had cut it,
Yes,
if
sir,
we had allowed,
yes, sir.
they would have not sent it to you.
So, but if something has another has been done, so
Yes, yes. If you have to malignant transmutation भी होता है क्या? Which is pretty malignant anyway.
So after making a final diagnosis of Gossipybioma, let's discuss what it is. So Gossipybioma, it is a mass forming around a surgical sponge which is left inside accidentally during a surgical procedure. The incidence following the abdominal surgery is estimated to be between 1 in 1000 to 1500 procedures. It is a very rare event, but can be also be because of underreporting of these events. The retained surgical item is the third most common malpractice in the United States. The reported incidence of abdominal cavity is approximately 56%. In pelvic cavity, it is approximately 18%, and in thoracic cavity, it is 11%. It is most commonly found in the abdomen and most commonly seen after cesarean section and open cholecystectomy, as in this case. It is infrequent but unavoidable surgical complication. The diagnosis can be challenging as the symptoms may not appear until the weeks or even years after the surgery. The other sites which have been reported other than abdomen to have a foreign body are nose, tracheobronchial tree, breast, pancreas, pararenal spaces, vagina, femur, and even spine. The most common detection methods are computed tomography, which detects up to a rate of 61%, radiography up to 35%, and ultrasound up to 34%. Coming to what are the various risk factors which leads to these kinds of retained surgical item inside the abdomen? It might be certain risk factors are the midnight emergency surgeries, the surgeries which involve a heavy bleeding, long hours of surgery, a team fatigue, or if there is any unplanned changes during the operation, or if the patients who are having high body mass index, then there is a higher risk of retained surgical item. The retained surgical items. So it can be means first of all it is.
Where was it done, by the way? Who had done it? Like which hospital? Do you know?
Open cholecystectomy.
Whether they had team fatigue, long hours of surgery. And this is an elective case. None of these elective cases.
Why was
It can-
cholecystectomy done?
In view of cholelithiasis, sir. It was done in a local hospital in Kishan Nagar. Might be laparoscopic set was not available. So
Shinagar is UP.
yes, ma'am.
Or was it that there was some problem during lap procedure
Not
and it got converted into open?
No.
So our routine procedure became an emergent procedure. And then they had to do a open.
A difficult cholecystectomy electively is not an emergent procedure. It's a planned procedure to convert when you can't progress in the surgery. And the usual time is taken to 15 to 30 minutes. Right? What was the exact reason we don't know because there was no documentation. And 5 years back, the patient also did not have papers, or probably they did have, or they did not show us, or whatever it is. Another thing which is missing in this list is that, as Dr. Shalini was pointing out, that radiopaque thing, right? The radiopaque marker. These are the gauze, not a sponge. And gauze don't have radiopaque markers. In India, at least, they cut off the gauze from a big thumb and make gauze pieces, and they don't have radiopaque markers. Second thing is, the gauze is more common to produce a Gossipybioma than a sponge. Because sometimes during surgery, you need a small peanut, so the gauze is cut. So count is lost sometimes. If the nurse, the trolley nurse or the surgeon themselves are not very aware, very keen and very meticulous, so that count becomes a problem there, right? A peanut, a putna saw, they cut the gauze and roll it into a peanut and then finally give to the surgeon. The other half of that remains as if they need multiple peanuts like that, so that can create a confusion.
So after how many days the histopathology report came?
It came approximately means 20.
In usual time, na?
Yes, ma'am. Unusual.
20
Where did you receive the picture?
I think within 1 week we received that picture.
So the moment they cut it, they send us the picture.
So means after 1 week.
Yeah.
After 1 week, till that time,
One dross.
you operated the case as mesenteric cyst.
Yes, ma'am.
So follow-up of the case,
Ma'am, patient was admitted.
everything was okay?
Yes.
You were happy with the diagnosis of mesenteric cyst that time?
Yes, ma'am. Intraoperative.
Of mesenteric cyst after surgery.
Yes, ma'am. Means
Between the stomach
They
and
Transverse
operated
colon.
and post-operatively it was treated as mesenteric cyst till 1 week. Till
1.
so no further follow-up was necessary for mesenteric cyst.
Patient was called for the follow-up, but by that time already we received the histopathological report.
Can you?
So, retained surgical items are associated with certain complications. There can be early complications and late complications. Early complications involve pain, infection, hemorrhage, obstruction, peritonitis, organ damage, nausea and vomiting, wound dehiscence, or delayed healing. Late complications might involve formation of adhesions, fistula formation, abscess formation, bowel perforations, even sepsis, chronic pain, or nutritional deficiencies. Pathophysiologically, there can be an exudative gossipybioma in which there is an inflammatory reaction in response to the foreign body, which can complicate and lead to an abscess formation, fistulas, or sepsis. Or it can there and in a certain amount of time there can be fibrinous gossipyomas in which a retained foreign body is encapsulated within the scar tissue that eventually forms a granuloma, which can migrate to the bowel, causing the obstruction. Unlike the exudative, fibrinous is a late presentation 60 days after the foreign body has been retained. So, the management of gossipyoma is the surgical exploration. Certain preventable measures which can be done to prevent these kinds of incidences to happen are that counts to be done in the various phases during the surgeries. The optimal environment inside an OT is must to maintain a focused performance. Surgical safety protocol to be implemented within the institutional policies. A proper training and room guidelines with the proper method of counting surgical sponge and instrument should be made and should be taught to the residents as well as the scrub nursing officers. And the radio opaque markers means the gauge or the mob that will be used should be labeled radio opaque. So this is a flowchart on inside like how we should respond when during the surgery. If during the OT, if after completion of it, we found that there is a disparity between the use of the surgical mop and the count that has been left after the surgery, then immediately we have to notify the team ID and including we have to notify that what is the type and what is the number of the item that is missing. After receiving a verbal acknowledgement from the surgeon, all the team members have to remain in the operation theatre and they take immediate action. The scrub nursing officer the surgeon has to first search for the mop piece inside the inside the sterile field. The scrub nursing officer has to organize and search the sterile field and should recount it, as well as all the circulating nursing officer has to come and count for and search for the missing item outside the sterile field. The anesthesia professional has to plan the anesthetic milestone accordingly, and the actions has to be taken so that they do not pressurize the team to perform an insufficient count in reconciliation practices. If the item has been found, then if it is yes, then recount item. Then we have to recount all the gauze pieces and mop and the surgical items. If it has been found, then we have to resume the wound closure and document is that the count is correct. If the item has not been found and if we see that it is a radio opaque, then we should try to obtain an intraoperative images in collaboration with radiologist. The surgeon should confirm an entire surgical field is captured on the images, and the radiologist and surgeon simultaneously review the images with interpretation. If the item has been found and if the surgeon believes that retrieving the item would benefit the patient more than the harm, then it should be retrieved and the recount has to be done. After recounting, we have to resume the wound closure. But if the item has been not found or surgeon believes that retaining the item would cause more harm to the patient, as patient might suppose if the patient is not stable and recounting would delay it, so we have to discuss and if also one more thing that the item which has been left is not radio opaque, then we have to discuss the alternative images with the radiologist like CT and MRI to find the missing item. We have to discuss with the patient and the patient representatives the benefit of the risk and the benefit of potentially leaving a missing item is found and in the wound, and develop a plan for the follow-up care. We have to inform the patient as well as the attendants. We have to resume the wound closure and we have to document that reconciliation measures were taken, the patient notification and the consultation was taken, and the location of the item and the plan for the further follow-up has to be documented. And the counts in the field, documents has to be documented as incorrect, and in a post-operative period, we'll take the measures to find the missing gauge piece or the surgical item. The National Quality of the Forum of USA and Health Department of UK have declared the presence of the retained surgical sponge as a never event as it causes a significant morbidity to the patient and the additional cost of the redo surgery with serious medical legal issues. So, those are the references.
Can patients sue that hospital?
Yes, ma'am. They can. Yes.
Here they got the report, so they came to know what it is, and they got a consultation from outside also, that it is a missed cause. Now they are trying to sue that finish the surgery. That's the last follow-up they said.
Can I say something?
That is the reason why Gossipybioma is mostly under-reported. Because once you come to know beforehand, before the surgery, that you believe in what it is, you just take it out and then dispose it. It doesn't go for pathology.
So how will you give a feedback to this family or to the doctor who's done it? Because the idea is to avoid such situations.
Yes.
Mistakes do happen. So how do you give a feedback to operating surgeons and to the family?
Means to operating surgeon, we would first will inform him if we know that where it has been done and we know the operating surgeon, we would inform him that this kind was done, and we will ask him to find what were the, like we discussed the risk factors, to what were the cause of this, to go to the root so that it doesn't happen again. We have to inform him, and if we are talking regarding the family, so we have to counsel them that although it is a never event, like it should not happen, but we can counsel them as we are in this profession. We can counsel them that these kinds of mistake can happen and there can be various reasons for it. So and if the like it depends also, patient counseling also depends on what is the status of patient after removal of Gossipybioma. If he is sick, then it would be difficult. But if the patient is also fine and it has been retained, then we can counsel that these kinds of mistakes do happen, and there is we can take steps to prevent that it further doesn't happen.
So
Any comments from the audience?
I think we have spent the time.
Okay.
You can just sum up.
This was an interesting case, and Gossipybioma should never happen. So surgeon and their team should make a count before the surgery as well as after finishing the surgery.
It's a never event. What is it in India? Do we have any status on this? That it should never happen?
The operating rooms are well equipped with doing intraoperative X-rays.
No, not all are.
Not all are. That is the reason why these guidelines is very difficult to follow. Second is that WHO checklist where the counts have to be done and all. Most of the peripheral hospitals where patients are operated, they don't have nurses. The nurses who are working there, they are actually nursing students who do night duties, shifts from while they are doing nursing colleges. Or they are the makeshift arrangement. There's a multi-purpose worker. So they are attending, they put on a nursing gown and then they become nurse like that. So inadequate training, that's the most important. The worst part was when the patient came to us on follow-up, they got the report from the pathology because they had just like they said that you're sent, and because of they're sent that the report has to be given. So they collected the report from the pathology, got it evaluated from somewhere, and then went to that surgeon who operated on this patient. According to them, the surgeon was angry with them and then shoot them off. If that is an area, we have to admit, first of all, we have to admit. And then so they are angry. And this anger doesn't happen once we admit that, events can happen. There are reasons for it. Nobody does this purposefully.
Okay, I think you made a very
Thank you.
good point. That you have to counsel the family